So now we have, last week we had our first case presented by our housing authority friends, and this week we have our first case presented by our Quitline friends. So I'm going to turn it over to California Smokers Helpline to discuss their question and case today.
Okay, thank you. So I'm Sharon Cummins. I'm the Director of External Affairs at the Helpline. We also have Leslie Phillips here, who runs our, or manages the Center for Tobacco Cessation, which is our training arm, and Carrie Kirby, who also works at the Helpline, and she's more familiar with all the e-referral parts. So I have them here in case I can't figure out what I need to be saying. So what we decided to do was just give a little bit of insight into some of our e-referral situations. So I was asked to think of something that might be, you know, a systems-based dilemma. So we've worked with a lot of different partners for electronic referral systems, and some of our early ones were through UC Quits, which used the UC medical centers, and we worked through their electronic medical records to set up portals back and forth. That's branched out to California Quits, but the one that I thought I would talk about today, mostly because I just think it illustrates the point that we're having, which is that it can be very hard to sustain the rate of referral once the system is in place. So this was through Los Angeles DHS, Department of Health Services, and they have a system that they call e-consult, which is their way of transferring people to getting them hooked up with specialty registries or specialty groups. So, that's what I'm going to be presenting today. Again, what we're trying to do is find a way to get these proactive referrals to the Quitline to be set up in ways that make them more sustainable, because they can be pretty labor-intensive processes. Currently, mostly the way we have this happen is there's a champion in each of the healthcare systems or clinics, and they help determine what is the workflow, where we can fit in the development of the electronic referral. Then IT teams from our end and the other end get involved to try to move it to an automated system. We find ways to set up the orders so they're built into that healthcare system or healthcare record. So this one that I'm presenting is e-consult system through LADHF. And it was recently presented in a poster at SRNT. Angie did that from UC Davis, and I thought it was really good. So if anybody's interested in that, I think it would be great for you to look into it. But the key components here are that the clinics that through LADHF all have different electronic medical records. So to try to find, you know, one system that can be used across all these clinics is very difficult. But all of them use this e-consult program, which is how they refer those patients to other providers. So what they decided to do was use that same infrastructure, build in the referral order, and then try to get that into the workflow. So the orders would not need to be set up by the physician, although once it's set up, the physician needs to be the one to confirm the consent and get it sent over to us. What's happened is that only about 8% of the physicians who have access to the e-consult system have actually sent a referral. And then, even worse, of those that do, 55% have only sent one. So I was asked to sort of briefly describe what my vision would be if things were working well. And if the system's working really well, then you have kind of a slow adoption period as you train people and you get more buy-in. So the referrals will sort of increase over time. And then at some point, it becomes a relatively stable number of referrals. That number of referrals should be a function of the size of the site, how many people they see, and also the prevalence of smoking. So there's going to be a maximum end to it. There might also be some differences in referrals based on the population that they serve. There may be some people that are more likely to provide consent for that referral. And we see that pattern in a lot of the UCs that we've worked with. There was a slow adoption period. It sort of eventually got to a kind of sustainable referral system. But even with that, the rate of referral gets maxed out far below what one would expect given the size of the clinics and the numbers of people they see and the prevalence of smoking in their population. So there's real limitations, and the limitations I think have to do with the same issue, which is this generalized initial enthusiasm followed by a kind of I'm not gonna do this. What we have found is that the rate of referral can be sustained better if you have periodic trainings for new staff and a succession plan for site champions. We like to have a site champion. And then it does work better if the system is minimal work for the physician. So for example, other people that's the wrong queue, but queuing up the order, putting it in the queue. So in terms of the LADHS process, the referrals dropped off remarkably from I think we were getting at one point maybe 70 consults, 70 referrals a month, and over the past 4 or 5 months, it's gone down to about 10 to 16 referrals. Yeah, so here you go. So this is by quarter, so that's adding them up over the quarter. So you can see the market drop off. So the other question that was posed is, what data do we have? And we do have a lot of data that we can look at. This referral rate over time is the primary one. The other things we can look at is the rate of contact to the patient. So that can help us work out glitches. So for example, if we get a batch, instead of getting referrals in real time, we end up with a batch of referrals, and sometimes those patients it's been a long time since they've been seen by the doctor, and that can decrease the effectiveness of the referral. And then we can also look at the rate of engagement of people who are referred this way. And that's often a question of how well the person who is getting the consent has set the whole situation up to make it sound like they should take that phone call from the Quitline. So if they've talked up the Quitline and said this is a really great way of going, then it'd be more likely that people engage. So those are kind of the data that we have to work with. And what I was hoping to do is just get some ideas about what direction we should be going. I think one big question is, should we be relying on these training methods? They're very time intensive. People, the turnover rates in clinics are high. Should we be try more and more to just make it automated so we're bypassing most of the people? So I thought I would just open that up for discussion. Now, did I miss anything, Carrie or Leslie? All right, so we're interested in your thoughts.
That's great. Thanks, Sharon and California. Super interesting, and probably a common problem, I'm guessing, the problem of challenge of the Quitlines keeping the referrals up so they're utilized, but also I think the challenge within the health system of recognizing and remembering that the Quitline is ready to help and has really valuable resources and services available. Before we move into some discussion on problem solving around this, any clarifying questions? Anybody want more information on any part of the process?
I want to clarify one thing for myself, and that is that we're continually surprised at how few people, even, we're at UCSD, we've been here for 25 years, we've worked pretty hard to get the message out. Just very surprising how often we run across healthcare providers who had no idea that the helpline exists or that it's a resource for their patients.
Yeah.
So this is Steve.
Agreed.
Question.
Yeah.
Is there a listserv or a generalized, is there a way you can contact all at once, the various champions, or would you have to do that one at a time?
Well, I think that was one of the things with the LADHS. There's really like 4,000 people that can have access to this program. And so there was a generalized email that went out. So yes, I don't know if it's considered a listserv, but that we can get the message out in a broad way. Yeah.
And then as far as the champions at each, so also like when we had, when it was UC Quit, there was champions at each of the sites. So we could talk to just those champions together as a pool. It gets a little more difficult when we have, 35 organizations where you might have one champion or two champions, but they're different systems. So we don't necessarily want to talk to all those champions together because they are doing things a little bit differently. So there isn't a real easy way to talk to all the champions. It is a little bit more individual, which then becomes a little more time intensive and a lot more resources to kind of keep them going.
And part of what you see in the quarterly data that I put up there is that there were a couple of moments where it kind of spiked a little bit, and those do seem to be related to, like, for example, putting a banner up as people go into the electronic medical record saying, don't forget to do this particular thing. And it'll cause a bump for a period of time, and then it kind of fades away again.
Yeah, I can see.
Oh, there's a question.
Sharon, one question.
Go ahead.
Go ahead. During the period where the referrals dropped off, were there any significant changes in the system that you're using or the technology or the methodology at all?
I don't think really. I mean, well, I guess the short answer is yes, there was a little bit of a difference. I think one possibility is there's been some recent concern about kind of the safety, security issues. And so maybe word has gone around about that. And so some people are reluctant to go into the e-consult and send information. So that's a possibility.
One other thing with the e-consult too is it's within a different platform. So they're working within, so a physician that is at LADHS, what they use is, they're using ORCID, that is their EMR that they're using, but they have to generate this referral to the Quitline, they actually have to go to another screen or open up another window, which is the e-consult. So they're a little bit different where they're not exactly built into their workflow. So there are a couple extra clicks. I do see a question from Jamie about what does the order look like and does it take a lot of clicks for the provider? And that is a very good point. We have a couple organizations. Ultimately, we try to make it as easy as possible because we know providers are limited in the amount of time they can spend with a patient. And we know if it's very difficult, they're not going to do it, right? So when we do work with these systems to build it into the order, we try to make it as few clicks as possible. So most of the time where it's built in now is at the point where they're doing tobacco assessment. So asking if the patient is a smoker, are they interested in quitting? And if they are interested in quitting, at that point, having consent pop up right there. So really it's only an extra click or two. Alameda Health System is an organization that we worked with, and they really took some time to make it so the clicks were not very many. They originally had to do like 15 clicks to do referrals and tobacco assessment, and now it's down to 5 total clicks, which includes a referral to the helpline. So they have seen their numbers increase dramatically because 15 clicks versus 5, people are going to be more apt to do 5. So that is definitely one way when you're working with systems to make it easy on people is if they have to do a lot of stuff, they're not going to do it. Some organizations have tried to do where a BPA will pop up, which is a best practice alert. So you can't move on unless you hit something. The problem is physicians have to do so many things that they often have a problem when these alerts come up and make it so they can't move on. So most of the groups that we've worked with don't have a hard stop where they have to do something to move on. So they can bypass it. So that if someone is smoking, they don't have to do it. But we do try to make it so there aren't very many clicks so that it's easy on them. And really what we try to say is do the assessment, and then send them to us. So let us be the ones to then provide the service. We know you're limited in the amount of time, so send them our way. But even with that, it's still very difficult.
Yeah, those are great questions. I think the click fatigue and alert fatigue is really real, and that makes a big difference. I'm curious, I have one question. Have you, when the trainings that happen within your systems that you're working with, are those mostly providers, or is it sort of like the provider and the team? And has anybody had success with like a standing order kind of process where through the vital sign process and the assessment of tobacco use, then it just sort of generates the referral if the patient says they're interested in quitting automatically without like sort of bypassing the provider?
So Alameda is one where their medical assistants are the ones that are doing it, so they're bypassing the provider altogether at the point of doing the assessment. So exactly like you're mentioning, they're going through vitals, they're checking other stuff. Are you a smoker? Yes. You want to quit? Can we send your information? The medical assistant's doing that. Others are still having the provider do it. Others are having a medical assistant, maybe sometimes a nurse tee it up, because the provider is the only one that can submit the order. So it depends on the organization, but that's a great point, because if you can bypass the provider, you're probably going to get better results, because the MA, if they're doing it at the point of assessment, they have the time built in. It just makes the process easier.
Yeah, that's great to hear. Yeah, the providers are good for lots of things, but completing these kinds of referrals we're not so good at usually. So yeah, that's great to hear. Any other clarifying questions or other thoughts before we move into some more discussion? Problem solving? Yeah.
One quick point, and I think Sharon covered it before, but in the spike periods where your numbers were up, I think you said you did listservs or some other kind of communication with providers. And I don't know if you could replicate it again, or if you're afraid of fatigue if you do it too often. Also, was there anything else associated with, for example, quarter 4 of 16 or quarter 3 of 17, where you had the spike?
Those were associated, yeah, I mean, one of them, let's see, the one in 16 was really putting in the helpline banner kind of at the beginning of the opening up the medical record. The other spike had to do with e-blast, and then the kind of a final spike had to do with creating a two-way interface so that they can get some information back. Yeah, what they've now done is reinstated the banner, but it doesn't look like it's really bumped things up very much. Maybe it's too early, maybe it's just gone in.
Have you, and this will be the last question I'll ask, and have you reached back to the providers and asked them why the drop-off?
I don't think we've done very much with that. One of the problems that we were having is that because of the way they send us the information, it hasn't been clear exactly who the providers are who have been referring. So we know the numbers of providers that have referred, but we didn't know who the provider was. I think what we're trying to do now is figure out if we can, when the information comes to us, if we can parse out, like as a result of all the stuff they send us, parse out who those people are, and then maybe we might be able to get back and find out at least what makes the people who are referring different, perhaps, from the others. That's
great idea.
Yeah, that's great. Interesting. Any other thoughts for Sharon and the California team about ways to maintain interest and even generate more interest in referrals to the Quitline?
Yeah, this is Frank. Don't take my exact language here as what to do, but what I've worked with some systems where they don't really ask the question, do you want to quit? Or whoever's working with the patient simply says, okay, you're a smoker. I really feel that it's important for you to quit because of blah, 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 connecting it to the diagnosis, and I'm going to refer you to the Quitline. And they just do it. So that kind of forces the patient to say, well, I don't want that. And what they have found is that many people won't say that. They'll just say, okay. And then, as you're saying, then that leaves it up to you to do the work, and it makes it even simpler for the physician. And what they did this with, and another, what I was going to bring up, is they picked key diagnoses to do this with. So like every single person who was diagnosed with COPD, who was a smoker, you know, they were approached this way. And every person who had cancer, every person who had heart attacks, you know, so you'd pick the conditions that are obviously caused by or exacerbated by smoking as the way to ease this. And then hopefully then, you know, that the physicians will get comfortable doing it with those diagnoses, and then maybe then expand it to everybody then who smokes.
So that's
I love that, Frank. Go ahead, Sharon.
No, I think that's worth looking into, kind of passive consent, and you're not asking them to affirmatively say they can have their information sent. They just didn't protest.
Correct.
Yeah, it's like an opt-out versus opting in, sort of an opt-out kind of system.
Right, that's a good way of putting it. Yep.
Yeah, this is Amy Scora, and I was just going to echo that, and with that opt-out approach. So with the University of Wisconsin, that is what we have been having our health systems do with these types of referrals and the language that they're using. So, you know, so they're not able to, you know, say yes or no right away unless they don't want the services. We're going to present it in a way that they're opting into that unless they decline for whatever reason. But we've seen that that does help. And it's easy enough for the clinicians to do. So that opt-out approach might be a really good kind of tactic to use. Also wanted to mention with training, if there's any way to do some type of follow-up or refresher type trainings, those can be really helpful to keep things, you know, fresh in their mind, to kind of put that buzzword of tobacco and these helpline referrals kind of back in at the top of the plate for those clinicians or those that are making those referrals. And also maybe switching up how the trainings are presented. So if you can do in person, that's great. If there are online trainings, to be able to, you know, send out an online training and make that mandatory for staff to view, just to get, again, that refresher for them. If they are interested in having some type of, you know, role play of the intervention. So sometimes it's helpful to have kind of that scripting and to watch somebody, you know, clinician and a patient kind of do that role play and kind of get used to how that language is presented and, you know, kind of the feedback from the patient, that sort of thing that can be helpful to share, you know, quick 2-minute video of that intervention and referral to the helpline. So, yeah.
I found that the grand rounds format is good for presenting this because doctors are used to that. And so they kind of are expecting to be there anyways for that hour each week or however often they do it. So if you can sneak it in during that, I think you'll get a lot more people listening to what you have to say.
That's great. And Linda or Steve, did you have anything to add?
Well, I would just add a couple things that may require more resources and time than Sharon has, but two principles that seem to work in this area are greater touch and competition. And so we notice this, you know, when the TIPS campaign comes out, you get a huge spike in referrals to the Quitline and then it falls off. So there needs to be the constant repetition. The other thing, Sharon, you mentioned you've been in business for 25 years, but most of the clinicians haven't. So they keep producing new ones who don't know about you. So there's a need to get continued touch, and it might be worth you doing some brainstorming about how to do that. And then a competition just to show variants of the kind of slides that you showed to see. And the dental hygienist did that here in California and had a competition, actually had a prize. The person who sent the most referrals got a trip to a conference. But those are two principles you ought to think about whether you can incorporate into the reinforcement mechanisms.
That's helpful.
And
Thanks. Yeah, go ahead, Linda.
And this is Linda. I just wanted to build, I guess, a little bit on what Steve said and ask Sharon if any of the healthcare organizations have built in any incentives or rewards or even expectations, performance measures for clinicians that you need to be referring X proportion of your patients. We can sort of estimate within the population what the smoking rate would be. And I think having the healthcare organization itself build in and set expectations also can help change physician behavior and get people to be asking more about smoking and figuring out how to use their system to make referrals. So I did want to ask you about any incentives or rewards or expectations that are built in that really are a systems change within healthcare. And I also, I know Wisconsin has done so much in terms of building referral rates. Wanted to see if Amy had any advice in terms of rewards and incentives.
Yeah, that's a great point too. We definitely try to tie in any type of quality or performance goals. We typically, we have the high mark of saying, 50%. We want connection rates. We want them to use those services. I think we're seeing probably typical to what you all presented as the case today, around maybe 35%, I believe, from the abstract that I saw was your connection rate, which I think is pretty standard. We do see that using, as champions with those clinician champions, to look at other types of champions as well. So quality improvement is a big one. And again, that ties to those performance goals and measures, meeting or improving rates of the tobacco cessation counseling given. Those are kind of the gatekeepers for some of those. So to have them as champions and can kind of oversee then the health system as a whole, and then kind of give those orders or put those goals in place can really help to improve performance and those referral rates as well.
Great, thanks everyone. For sake of time, I'm going to move us on, but I think we had some great ideas. And Sharon and team, feel free to come back to this group, in a couple months or after you've tried a few things, and we can, brainstorm some more, do some more problem solving. And other Quitlines, do you have the same or similar kinds of challenges about getting your referral rates up? Hopefully there's some good ideas for you all as well.